In the 1950s and ever since, Children's Hospital was the center for pediatric care.
It was looked upon by Pittsburgh as one of the gems of the Pittsburgh area.
There was one day where our chief resident, Dr. Lee Bass, had informed us that Esther Bubley would be coming to the hospital. She was a photographer. And he said that she was going to just be around taking pictures of whatever was happening in the hospital and hopefully at some point perhaps utilize these pictures for the promotion of Children's Hospital's name.
Everybody knew she was coming. And the big talk was Life magazine was going to have her there, and it was going to be on the front page of Life magazine.
Many times she was referred to by the other doctors as Dr. Bubley because they respected her work as well.
It's probably the most thorough assignment project I've ever seen put together. I mean, when mother and child came to the hospital, she photographed them walking up the walk to the doorway to the hospital, and the same when they left the hospital, and everything that happened in between. It is an awesome coverage.
Oh, the hospital was a lovely place. It was very compassionate. It was very thorough. It had people that were very knowledgeable. It was a joy working there. It had a reputation of being a great children's hospital throughout Pennsylvania.
I started as a resident at Children's Hospital in 1951. There probably were no more than 15 pediatricians in the whole city of Pittsburgh. We all lived at Children's Hospital in the residence quarters. It was like one big family. And the camaraderie was great.
We were few in number, and we also were operating a hospital of approximately 300 inpatient beds. And being that we were few in number, a considerable amount of the work pertaining to the workup of a patient was our responsibility.
Every patient that was admitted by the next morning should have a complete history and physical on the chart, plus a urinalysis and a complete blood count. We did our own urinalyses, we did our blood counts, and any other test that was necessary. We worked hard. It was a hard life as a pediatric resident in those days.
One of the interesting tasks that the residents had in the 1950s was sharpening needles. The needles had to be reused, and of course they became dull, and they had to be sharpened, usually on a regular sharpening stone.
We didn't have all the facilities we have now. For example, we had to draw the blood on every patient that we took care of. We had to give the transfusions ourselves. There was no IV team.
We not only typed and cross-matched the blood, we also took the blood to the patient and administered it to the patient. And starting IVs, that used to be a very difficult procedure. It wasn't unusual for us to try veins anywhere we could find them, be they scalp veins. We would try wrist veins, leg veins.
Drawing blood, which was so terrible at that time, you had to do that. And we drew it from the jugular vein, believe it or not. The nurse would put the patient over the table and they'd have the baby cry, and this jugular vein would become prominent, and then you would draw blood from that.
We all helped each other out. The older residents taught the younger residents, and the younger residents taught the interns and the medical students. We got to know each other quite well and got to rely on each other. It was as I say, one big family.
In November of 1950 to 1952, I was a resident at Children's Hospital in Pittsburgh. And during my second year there, I was assistant chief. It was appointed to me by Dr. Lee Bass.
Dr. Bass had an affinity for children. Although he did not have to, he would go from floor to floor, visiting patients in various rooms, and he would be rather encouraging. He would try to offer them hope in situations, and he would try to offer them a better prognosis, even if the situation was rather grave. His concern about his patients was such that he would worry about them even after they had been discharged. And I do recall one incident when he said, come with me, let's get in my car here. We're going to go visit this patient. I want to find out what's happening with this patient. And we drove to the patient's home up on the hill above Children's Hospital. And we knocked on the door, went in, and the mother let us in, and we were chit-chatting, speaking there, and finding out what was going on. And we were rather pleased to find that the patient was progressing rather nicely. But this type of warmth and devotion to patients was really something that was rather infectious. Actually, it became part of our personality, as a matter of fact.
We had one particular child who had osteomyelitis, and he just happened to look like President Ike Eisenhower. And Dr. Bass named him Ike, and he was one of Lee's favorite little patients.
One of the things that was apparent in Esther's work was that she was one of those experts, which we had a few of in photography at that time, who disappeared as soon as they were with a camera and on a job. She just wasn't there. She was there photographing and understanding and looking and interpreting, but nobody knew that she was there. She disappeared.
And there was one time that she took a picture of me in bed, and I said, Esther, how did you ever do that? She said, I put on the light and you woke up, you had a telephone call there, and I thought I'd just grab you.
There is a sequence of pictures that were taken in the emergency room, and they are a tribute to the way the hospital at that time handled the patients.
I remember an experience we had that was very traumatic, very important. It was the case of Patty Clark. She was a young girl that came into the hospital with difficulty breathing.
This was on a Sunday, and we were in our lunchroom on B floor at the hospital when we got a call that there was an extremely ill youngster in the emergency room, a floor above us. She had severe respiratory distress. As a matter of fact, she was gasping for air at that point.
In certain cases of difficult breathing, the infection affects the epiglottis. The epiglottis is the valve that covers the trachea. And in Patty's case, the epiglottis was so infected from her infection that it could not stand upright. And that's often hard to diagnose. And when you see the person like that, they're often turning blue. And you have a few minutes only to save their life, to get in there and open that.
We were about to perform a tracheotomy, even though we were not surgically trained. And when Dr. Silverblatt came in, and he said there was no time to obtain anesthesia, or there was no time to play games, essentially. We held the youngster in the proper position, tilting her head back so he had exposure for the tracheotomy. And immediately Dr. Silverblatt made an incision. I do recall with one incision, he was through the tracheal rings and had opened up the trachea. and began to suction, and where she developed immediate relief with her breathing.
I was impressed with the teamwork. Everybody came in to help. Those of us who didn't want to get in the way stood in the background and would help if we were needed. And we watched how these men got together and did a tracheotomy, put a tracheotomy tube right down, not in the OR, right there at the scene. And little Patty Clark's life was saved.
I went to speak with the caretaker who was the foster mother of Patty Clark. I still remember that poor woman. She was raising her hands and wondering, oh my, and whatnot. And she just felt so helpless at the time that she just could not do anything for Patty at home. Actually, thereafter, she stabilized, and she probably was in the emergency room probably for about an hour, perhaps about an hour and a half, and afterwards she was moved to the floor for further management. She was rather ill throughout the course of that day, being lethargic, being tired, and even not being very alert. But I recall going to the floor on the following day, at which time she was an entirely different youngster. She was sitting up inside of her oxygen tent. She was alert. Could not talk because of the tracheostomy tube, but there was a difference in the young lady's behavior and performance. It was a rather harrowing type of an experience, but I remember that it was, everything happened so rapidly, so quickly. We really didn't have a whole lot of time to sit down and plan what to do. It was just rather instinctive for us to go ahead and do what we had to do.
I was a general surgeon at Children's Hospital from 1950 until 1990. Surgery was not a prominent part of the activities at Children's Hospital in the 1950s. The type of operation was much simpler than at the present time and presented little risk in themselves. Appendectomies and hernia operations were commonly done. But by far the greatest number of patients had infections and required a drainage of abscesses. The operating rooms were much simpler than those of present era. The lighting was much more primitive than what we have today. The primary risk in those days was the anesthetic. It was administered primarily by nurses. It consisted primarily of open drop ether. In most cases, a nurse would monitor the pulse by feeling the pulse. It was what I would consider the most dangerous part of the operation.
I first came to Children's in about 1950 or 51, and it was at the invitation of Ed McCluskey, who was one of the greatest physicians that I've ever known.
Dr. McCluskey was very important from the standpoint of the future of Children's Hospital. He had a vision of what a good children's hospital should be.
He was really the inspiration for bringing first-class medicine to Pittsburgh. And he did it by going out and getting people that he somehow had gotten word of, and then not letting go of them until they said we'd come. When Ed McCluskey made rounds, he was teaching from the bedside. The kids loved him, and he was able to evoke in them a feeling that they were being well taken care of.
Part of our training was they still prevail today, the Thursday grand rounds. We didn't call them grand rounds, we call them conferences, which took place in the classroom at Children's Hospital. One of our outstanding teachers was Dr. Bill Donaldson, and he gave us many, many lectures on pediatric orthopedics, especially dealing with club feet and shoes and things that we thought were important.
Al Ferguson was also one of my heroes at Children's Hospital. He concentrated on straightening out children with curvature of the spine. And it would take weeks to do this, but it's marvelous because the children would be so happy getting ready to walk straight, and he kept visiting them each day. He would crank the spine, and then as he did so, fill in open spaces with slivers of cartilage and bone about the size of matchsticks to stabilize the spine. And the children, they were told they'd be able to go to high school prom. And they did.
Dr. Gaffney was one of the outstanding pediatricians at Children's Hospital. As a diagnostician, he had no peers.
Paul Gaffney was one of my heroes at Children's Hospital because he saved many blue babies and RH babies. The blue babies were just children born with a heart defect, bad valve, couldn't pump blood through to the lungs in sufficient quantity to keep them going. And I remember one of his patients whose lips looked like he had just eaten huckleberry pie turned into a lipstick ad right after that.
Dr. Gaffney's teaching of grand rounds in which specific cases were discussed was especially well done and especially well appreciated by the younger physicians in training at Children's Hospital.
When you look at older pictures of hospitals versus today's pictures of hospitals, you don't see high-tech radiology in the old pictures of hospitals. You don't see the high sophisticated technology and instrumentation that we have today. You look at the old ones and you think, my goodness. But also you look at Esther's pictures of the nurses and the children and the parents, and you think, boy, that's exactly what I'd want to have in a hospital.
The length of stay was much longer at Children's Hospital back in the 50s, and the needs of these children who had long stays were many. They needed to be educated, and they needed recreation, and we had the people who could do that. They did a wonderful job. We had a great many volunteers at that time, the gray ladies and play nurses. And the nurses looked like nurses. They all had uniforms and had white shoes and all wore caps, and there was plenty of help. They were always available. You don't hear much about these people in the history of Children's Hospital, but I thought it was one of the great highlights of Children's Hospital at that time.
There was so much love generated by what they did, and I think you knew that the main aim in life there was for the child and the good of the child.
As we look at Esther's pictures from that period, and as time goes on today, I think the important thing to realize is that Esther was recording that human relationship that makes getting well a successful thing in a hospital. Whether you have high technology or low technology, a lot of it depends on the human relationships between doctors and patient, nurses and patient, parents and patient. But it's the human relationships that are liable to make the difference between getting well and not getting well.
When you see a case of Patty Clark, where you've accomplished so much, where you had a child where the results might have been horrible, and you see a happy, healthy, wholesome child leaving the hospital, you feel very overwhelmed with happiness and satisfaction. And that's pediatrics.